Good evening, everyone. Welcome to The Doctor Is In.
Good evening to all. I'm Dr. Monique Gary. I am a breast surgical oncologist outside of Philadelphia, Pennsylvania. I am joined here with my lovely co-host, Ricky Fairley, and you're tuned into another episode of The Doctor Is In. Relatable, reliable, and real information, especially for our breasties, but really for everybody. So we have an exciting show for you tonight. We want to talk about COVID-19 and when it truly affects us. I think everybody knows somebody who might have been diagnosed with the coronavirus, but we have some really visceral stories to bring to you today to talk about things that we wish we had known and our experiences, and really give you some information to make you feel a bit more empowered and prepared once you leave this show. So Ricky, why don't you start with the numbers? Give us the data on where we are with COVID-19.
Yep, and I'm Ricky Fairley, CEO of Touch, the Black Breast Cancer Alliance. So today the numbers are 3,416,428 cases. The new cases for today, 60,971. Today's deaths, the total deaths so far, 135,991 deaths so far, 773 new deaths today, right? Isn't that crazy? Just the numbers are horrific. I also pulled up some death rates for Black people. So I'm just going to read this data I found. The death rates among Black people between 55 and age 64 are higher than for white people age 65 to 74. And death rates are higher for Blacks age 65 to 74 than for whites age 75 to 84. In every age category, Black people are dying from COVID at roughly the same rate as white people, more than a decade older. Isn't that crazy? So the disparities can be observed at all ages, but are especially marked in somewhat younger age groups. So really, we're dying at all ages. These disparities can be seen clearly by comparing the racial deaths of Black and Hispanic Latin people in each category. Among those aged 45 to 54, for example, Black and Hispanic death rates are at least 6 times higher than for whites.
And you know, Ricky, we know that it's multifactorial why we're seeing this type of disparity, but fortunately, COVID-19 really has shined a light on the disparity and the increasing disparity in our communities with respect to our mortality and our morbidity from preventable illnesses as well. And, you know, no greater place do we see that disparity than we do in breast cancer. Isn't that right?
Exactly. It's
Talk about it.
The same thing. We know that Black women, you know, Black breast cancer is a different disease. I say that every show, that, you know, and it's really because we're dying, and white women aren't dying of breast cancer. But, you know, our mortality rate, breast cancer is killing Black women at a 42% higher rate than white women. And that's just unacceptable. Black women under 35 are dying at 3 times the rate. So, you know, that's the same trend here that we're seeing here. So
earlier disease, right? Earlier age, later stage. You're absolutely right.
So we have some fabulous guests today, and we have one just join us, so to talk about it. And we are so excited to have you guys on our show. And you know, we're pretty chill. It's, you know, it's not really a typical talk show. We never really know what's going to happen, but you know, I'm so happy to have a breastie here that I knew years ago. You know, Marie and I figured out that.
What's the backstory there?
Yes, so Marie. So when I was pregnant with Amanda, I took a exercise class, and I met Marie's best friend, whose name is Maureen, and we started a play group for our kids before they were born. And so Amanda will be 35, you know, in a few weeks. Wow. So that's how long ago that was. So Marie was best friends with my friend Maureen. So I've known her. I went to birthday parties with her for many years with our kids. And when we started talking, I was like, I know her. I know. And we tried, and then our friend Maureen helped us figure it out today. So, and now she's my breastie.
Well, here I am. I'm out in Sellersville, Pennsylvania. And a friend of mine, a doctor colleague from Philadelphia, says, hey, I have somebody. Can you take good care of her for me? She is a dear friend. She is my realtor. She is my neighbor. She is a beloved associate of our community. And I want to send her to you. I know you're a little far out of Philadelphia, but I want you to please take good care of this woman, because she has taken such good care of me. Yeah. And walks into my office, Miss Marie Pogue, who is just a fabulous, phenomenal human being. And we have had a wonderful relationship ever since her diagnosis through her treatment. But she came to see me, was it not even 2 weeks ago, I think, Marie, where we came, you came to see me for a 6-month follow-up appointment. And I'm asking you how you're doing. And I'm going through all my questions that I ask every patient, everybody's safe, COVID-free. And she said, well, guess what happened to me?
That's right. That's right. So I told you my story of how I had COVID-19. I was diagnosed on May 14th and tried to take care of myself on my own. Of course, I had been watching Chris Cuomo about 3 weeks before on CNN with COVID. And I thought, oh, if he can take care of himself and get through this, so can I. But unfortunately, my situation, each day I got worse and worse with all the symptoms. It started with a high fever, chills, body aches and pains, vomiting, nauseousness, and each day it became more intense until finally I started having lower oxygen levels, and a girlfriend called and I was gasping for air, and she said, Marie, you got to go to the hospital. You can barely breathe. And I said, you're right. And I called EMS. They took me to the hospital. I was checked in through the emergency room. And after about 4 days, I didn't seem to be improving of being in the hospital. And I have these close girlfriends of who Ricky just mentioned, Maureen Dotson. There are about 6 of us. We're like the 6 musketeers. And one of them called Joe, and Joe's wife and I are very good friends, and said, Joe, Maria's in the hospital with COVID. And Joe said, I'm on it. And Joe Austin called me, and Dr. Joe Austin in Arlington, Texas is a pulmonologist. And he called me and said, what is your doctor saying? And I said, Joe, I haven't seen a doctor. I've been here 4 days. I have not talked with a doctor nor seen one. So Joe told me to tell the nurse to make sure the doctor comes into my room the next day when he makes his rounds. And when the doctor came that next morning, he looked at me through the window of my hospital room, and I motioned for him to come in. And when he came in, I called Joe, and Joe kind of took over for me as my advocate. And it was just wonderful. And that started me to thinking that there is a great need for advocacy, especially among African Americans during this pandemic, because we are dying at higher rates. We are getting infected at higher rates, and at the older age limits as well. And some older African Americans don't know that they can have other people talk to their doctor on their behalf. And so maybe, Joe, you might want to jump in now and tell everyone what you did for me when you talked to the doctor at the hospital where I was.
Okay, well, I think that COVID is a disease that not everyone knows how to treat. There are some specialty hospitals that are better designed to take care of patients. And some of the outlying hospitals, the people who take care of COVID patients really don't know what to do completely. And what I did was talk to the doctor. I tried to give him suggestions on what should be done. He seemed to be pretty receptive of it, and he listened to me. But I think the hospital where you were, Marie, they had, I guess, residents rotating through it. The young doctors and some of the senior doctors really, they weren't your primary, you weren't their primary patient. In other words, you weren't being followed by them prior to being sick and being in the hospital. So they weren't your primary care physicians. And I think that's what happens a lot to our patients because they get admitted to the hospital nowadays. Your primary physicians don't even go to the hospital. They have hospital doctors, hospital-based doctors that take care of the patients that are there. And then they switch shifts. And before you know it, you have a whole nother group of doctors taking care of you that didn't know what was going on before. So what I tried to find out is, well, who is going to take the responsibility of taking care of Marie? And if they are, then let me help them through this. because as a pulmonary critical care and sleep specialist, we have quite a few COVID patients in my primary hospital. And I follow pulmonary patients and sleep patients when they're not in the hospital. So I'll still follow my patients if they get admitted. But many of them are patients who I don't know. I just meet them when they get admitted, and I get asked to see them on consultation. And for COVID, we didn't know what to do early on. I mean, we were throwing everything at patients, everything that we knew that could possibly help. We were given I guess, the anti-malarial drug. I never really gave it because I didn't think it worked. So a lot of people were giving it initially, but now I think they backed off of it because to me, it just didn't make sense. The other drugs that have come to play, one is remdesivir. We actually have good data on that. We know that it works. It works early on though. And we wasted some of it because we were giving it to patients who were critically ill on ventilators. And if you use it that late, it's not going to be effective. So we end up running through a lot of remdesivir. There's a medicine called Tamiflu for flu, influenza. And this is typical of that. If you use it within the first 3 days of coming down with flu, it is going to help. But if you try to use it after you've had flu for like 6 days, it doesn't work. So I think remdesivir is the same way. So that we use late. And I think we tried to help Marie through this. Over time, what the research has shown is that this is truly a blood vessel disorder. The virus attacks the wall of the blood vessel and irritates that blood vessel wall. And then that leads to clot formation. And those clots break off and get trapped in the real small capillary blood vessels. And because of that, patients have normal lung compliance. In other words, their lung can expand normally, but they just can't oxygenate because blood can't pass through those little blood vessels. So part of our treatment now is to put patients on blood thinners. And as you know, Marie you had to go on a blood thinner, and they actually wanted to do a V2, like a test to rule out blood clots in her. And I told them, forget that. She's going to be on a blood thinner anyway. So go ahead, Marie, leave the hospital. And I think she's still on the blood thinner now. I wanted to take it for about 40 days after getting out.
Actually, I finished it. I'm no longer on it.
Oh,
I finished
okay.
the
All right.
complete regimen.
So she never did have to get the pulmonary embolism scan. It didn't matter. It didn't matter because she was going to get the blood thinner. Did you walk out, Marie? I forget. Did you walk out, Marie?
I did.
Oh, okay. Yeah, that's what I thought. Yeah, because she has a problem with her blood vessels are very small, and I think she went through 3 or 4 different people trying to start IVs in her, and it just got out of control. So I got them to just hold off on that, and she was able to get out. So Marie, what do you think about that hospital? Is it a hospital? Are they learning how to take care of COVID patients better now there? Do you know?
It did not seem that way when I was there. And that's why I feel that patients should have advocates. The hospital where I was, there were nurses that were afraid to come in the room. The only time I saw a nurse is when they took my vitals. And a lot of times they would leave the food outside my door for about 20, 30 minutes. And when they brought it in, it was cold. Eventually I complained, but at the beginning I wasn't eating anyway because I was too nauseous. But after remdesivir, I could keep food down. And, you know, I just said, I didn't really complain. I just asked, why is the food always cold? And the nurse said to me, you know, we can put it in the microwave before we bring it into you. And after that, the food began to taste better because it was warmed. So that leads to the point where I think that a lot of people, when they go into the hospital, they're very sick. They need someone to talk to the doctor. It may not be another medical person, but a family member or a friend who can call the doctor and find out what's going on. I was too sick to really care at that point. I was hallucinating, had a high fever, and thank God for Joe, who just kind of checked with the hospital pretty regularly to see how I was progressing.
Well, if you think about it, I mean, my mom has been hospitalized many times. She has really bad asthma. So she has major lung issues. I live with our pulmonologist, Dr. Joe, but I would never let my mother be in the hospital by herself, ever. I mean, I always stay overnight with her. And even when I had my mastectomy, my family, my daughter stayed overnight with me. So I don't see how under normal circumstances, nobody should be in the hospital by themselves, you know?
Right.
Well,
but here
during
we are.
COVID, you have no choice. Yeah.
Exactly. And let me jump in here because I want to touch on that the very fact that no one can come with you, and I know Dr. Beliza, you're going to talk about that, and Doris Barnhill, hello, thank you for joining us. And I know we're gonna get your experience in a little bit, but when you can't have visitors, when the contact precautions are so severe. So Marie, give us a timeline about, when was this? Were people wearing gowns and masks, or wearing gowns but no masks, masks but no gowns, face shields, no face shields, eye protection? Because we have seen the CDC recommendations kind of go all over the map in terms of even how people should be protecting themselves. And hospitals didn't have enough PPE for a while there. So were you in a special COVID unit in the hospital? And how long did you wait in the emergency department? What was that experience like for you? Because I know that there are people who don't believe right now that emergency rooms are overcrowded and that, ICUs are running out of beds. They think it's something that's made up. And I wonder if you could just talk a little bit about that, even just your ER experience to, the wing of the hospital you went to.
Every room in ER was filled when I got there. I waited for maybe about 15 minutes before they took me into a room. During that time, they were checking me in. But once I got into the room, I had two very good nurses, ER nurses, who took very good care of me. The doctor came in, they took my blood pressure. They told me my blood pressure was extremely low and I was malnourished. I didn't realize that. But when I think back at it, I hadn't been eating for about 5 days. My temperature was high. They could not, because I have very thin blood vessels, they couldn't get the IV in. And I think they stuck me at least 5 times. And finally they took a ultraviolet light to find the vein and they were able to get the IV in at that point. So altogether, I was probably in ER for about an hour before they took me up to a room. I went on a ward. I'm not sure if it were all COVID patients. I was the only one in my room. It looked like a bed for 2 people, but I was the only bed. It looked like a room that could hold 2 beds, but I was the only person in the room. The nurses were not wearing shields. The doctor that came in had on, that time he came in to talk with Dr. Austin, had on a hazmat suit. I remember ringing the bell, telling the nurse that I was cold. She opened the door, threw a blanket on the foot of my bed and ran out. So I had, as sick as I was, to raise up, pull the blanket up and cover myself. It appeared that all the nurses were afraid of getting COVID. They did wear masks every time they came in. There were no face shields, but they would wear some kind of covering over their normal nursing outfit, like a large robe or some type. And I had the feeling that, and one nurse said that most of the regular nurses were not on duty. A lot of nurses were not working during this time because they had families, I guess. And the nurses that were working did not seem to be that experienced.
Were they afraid of you? Do you feel like they were?
I do. I feel like they were afraid to come in the room for fear of getting COVID. And at The second day I was to get remdesivir, the nurse came in and she didn't put the IV into my vein. Remember, Joe, I sent you a photo of how my
Yes.
arm swole up very large. And you said that's because she didn't stick the needle all the way to the vein and the remdesivir was going into my skin and swelling up my arm. And so when the doctor came, the head of nursing came in and I showed it to him. And they sent somebody else in to inject me again with the remdesivir. They got it in the vein this time. And everything went well. Because I think what happened from the first day of injection, the needle moved out of position and they were having a hard time getting it back in again. But the nurses where I was in the hospital were very afraid of getting COVID. I think they treated patients as if they were lepers. They didn't want to come in the room. Nobody, I was there for 10 days. My sheets were changed twice. I got so tired of waiting for someone to draw water in a basin for me to get a bath. And I had an oxygen tube in my nose. I just kind of took the tube off, went in the bathroom, washed off, put on a clean gown after day 4, and was huffing and puffing for air and hurried and got back in the bed because no one would help me. It was just that bad. I didn't complain to anybody about it because when you're that sick, you're more interested in feeling better. Friends were calling constantly. And I said to my son, you have to take over the phone calls and the text. And he was very good about keeping all my friends abreast with my progress so that they wouldn't call and disturb me because loved ones want to know how you're doing. But Joe was there every step of the way, every day, making sure things were done properly, even up until the last day when I was to be discharged. He talked with the intern about putting me on the blood thinner, and the intern wouldn't do it. He wouldn't write a prescription for it. So it was scary. The whole thing was scary. But once I
had your doctor order that, right? Marie,
yes, when
Marie,
I got
was
home,
it your doctor who ordered it?
It was my primary care
care,
doctor after I got home that you talked with who ordered the blood thinner. And she was very familiar with it and knew why I needed it. So you're right. Some hospitals don't have the same level of care and knowledge about COVID.
I would dare say many hospitals don't. And it sounds eerily reminiscent of the HIV and AIDS epidemic in the 1980s. You know,
Yeah.
when you think about those patients who could not get nursing care, their food was left outside for hours, they're weak, they're cachectic, they're frail, they can't even get to their bathrooms, they can't get clean
Right.
sheets. And it's something to watch it play out again here in 2020. And it's really very unfortunate. And you couple that with, let's say, a language barrier. What if English is not your first language?
Right.
Then what are you to do? And so here we have, you know, in cities and in states all across the country, patients who don't speak the language, who are afraid, who are not feeling well, they're sick, and this is their experience. And Doc, I know you're seeing it down there in Arlington, down in Texas, aren't you?
Oh, yes. I learned how to speak Spanish, medical Spanish anyway, years ago. But the idea that you're going to be there with the patient, you know, as a family member, that's not really true. Now, what we've done is we've tried to do FaceTime with various family members, and the hospital bought these displays, little monitors, so that we can bring it in the room and have them talk to their family members. But for a while, the hospital was totally locked down. We have neighboring hospitals that are specialty hospitals that are still locked down. You can't get in and visit a family member there. A lot of the nursing homes also, they were worried about someone bringing in COVID and then spreading it all around the patient population. What we've done, though, in patients that were really sick and likely to pass, we would get the hospice service to come and walk them in so that they could spend some time with their family member before the family member dies. So we were able to get that done, but it felt very weird, to take care of patients and not have family in the room or seeing the patient or what have you. Very weird. I never experienced anything like that before.
Well,
As far as the nursing,
yes.
yeah, as far as the nursing actually has stepped up. Initially, I remember some nurses saying, well, I got kids, I can't go take care of these patients. But later on, everyone got used to taking care of them and felt more reassured. So we have a really good staff of nurses that are out to help people and dedicated. So we've been able to select them. We have a full ICU of 20 patients right now. We have 2 floors, 20 bed, and then another 15 bed floor with COVID patients, and there's some more down in the ER. One of the hospitals, neighboring hospitals, has 31 patients in the ER waiting for a bed, COVID patients. So the ER is all blocked with patients. There are no beds, and it's only going to get worse, unfortunately.
Wow.
So in
Yeah.
Arlington, it's bad. It really is
Yes.
bad.
Wow.
Texas as a state as a whole is bad. And the
Yeah.
hashtag I've had this entire pandemic is that cancer doesn't quarantine. And so we have had to continue our care. I know Dr. Beliesia, you have been operating, and I want you to jump in here and talk about your experience as a physician during this time and introduce us to Doris so you guys can tell your story.
Sure. So I'm a breast surgical oncologist at Hackensack University Medical Center in New Jersey. So New Jersey and New York, as everybody knows, experienced their COVID surge back in March. And so initially, the way that we proceeded is that we kind of started to backtrack on the surgeries that we were doing. If patients could get by with medical management instead of surgeries, that's the way that we went. Doris is one of my wonderful patients that I love dearly. And she fell in the category of somebody who was able to have chemotherapy before her cancer surgery. And so she proceeded with that during the surge. And I guess that's where we can lead in with your experience, because you were near the tail end of your chemo, unfortunately, when you got COVID.
Correct. I just completed my, next to the last session. We canceled the last session for the chemo because of the onset of the COVID. I was diagnosed with it on the 11th of April, and I was given the hydroxychloroquine. And I agree with Marie, because I was sent home with hydroxychloroquine to take that, and I pretty much was on my own. I didn't have any of the major symptoms that most people experience. For me, it was exhaustion. And pretty much prior to my going into for the diagnosis on the 11th, I was experiencing a lot of nausea. I couldn't keep anything down. But once they rehydrated me when I went on the 11th and put me on the hydroxychloroquine, and that was it. The nausea stopped. I didn't have any fevers. I didn't have any of the symptoms. I did not have any coughing. I didn't have chills. I didn't have fever. I didn't have anything but exhaustion. I could have slept all day, every day, if someone didn't wake me up. But I also agree with Marie when it comes to having an advocate. I have a nephew who sits on several boards of several hospitals. And once he found out from my sister that I had had both breast cancer and I was undergoing COVID, he got on the phone with me and he said, I have to tell you how serious and the category that you're in. He just laid it out to me, it's amazing you're still here. So he had me send him my temperature every day. I had to, and any changes in my condition. There were no changes. I didn't have a fever, but it was every day. He got the name of the hospital. So it was Hackensack Hospital that I was affiliated with. And he's like, if need be, we will be in touch with them. If it ever gets to the point where you're going to have to be admitted, we know who to get in touch with, who to reach at this particular facility. But it never got to that point. He also stayed with me straight through breast surgery. He was there for that as well. He was constant on the phone with me. As soon as you get home, give me a call. And every day it was a call. How are you doing? There was such a fear in him that this is so dangerous and you're home alone. But he understood. There's no reason for me to go to the hospital. I'm here. I could go there for what? The only symptom I have, as I said, is that I'm exhausted. I cannot get out of bed.
So you had your mastectomy. When was that during the process?
The mastectomy I had just at the, well, I never got a diagnosis, a negative diagnosis until after I had the mastectomy.
So in other words, before you had your surgery, we kept repeating testing to see if the COVID had left your system.
Right.
And your test came back positive repeatedly, unfortunately, which made us have to, proceed with surgery in a special fashion, because when we were doing surgeries, we wanted patients to be COVID negative so that we could do it in our operating rooms. And if patients were still testing positive for COVID, we had to do it in a special operating room that was away from the rest of the main ORs. Now,
how was that testing done? Was that nasal swab? Was it other testing?
Yeah, just nasal swab.
Okay.
Unfortunately,
Well,
right?
actually-
I had that done like 3 times.
Actually, I had several done. I had the nasal swab. I had the blood, and I had spittle.
Okay.
So I had quite a few of them done.
And the nasal swab is the worst one by far. I'd rather do the spit and the blood any day.
Right.
But so even though you were testing positive, you were asymptomatic, and the likelihood that you had infectious COVID was very unlikely, but in an abundance of caution, the hospital preferred to treat you like you were positive with COVID. And so we did your surgery in that special operating room.
Right.
And we discharged you on the same day, which thankfully our practice had some experience with for the past year. Little did we know we were being prepared in some ways to treat COVID for our surgical patients. And so how was your experience, before surgery? Remember, we were talking about what was on the news that day.
Yeah, that was a bit much. That
Yeah.
was a bit much, just that whole situation. First of all, I was already in my own feelings about the surgery. That just was, I hadn't come to terms with that still, it's like, okay, I guess I'll come to terms when it happens. It was overwhelming for me. And then at the time now, I've got the Black Lives Movement going on, and I'm watching the television and I'm seeing what's going on at that point in time. The whole experience was, all I can tell you, it was overwhelming. It wasn't until after I got home and it was, things seemed to flow better at that point in time. The nurse came the next day, that helped out a lot. It was like, okay, I'm not doing this alone. Because really the only person I had was my son, who came to stay with me to help me get through this process. So, but it's only so much he could do. He could make sure that I ate, I had food and different things, but I think it was a little more required for me. So when the nurse showed up the next day, that particular Saturday, it was great. She spent time, she asked questions, and it was great. She wasn't in a hurry. It wasn't like I'm rushing in and rushing out, she spent time. And then every other day there was a nurse. So for the next couple of weeks. So it wasn't bad. It wasn't bad at all.
Yeah, I was going to say, I'm just having a mastectomy is horrible in itself. I was like, who did your drains? You know what I mean? Like, it's like.
I did my drains.
You did them
I
yourself?
was,
Oh my gosh. Okay.
yeah, I was shown how to do them. So it wasn't bad. I was able to do them.
God bless you. We still have an
God bless.
overnight protocol in our hospital. So my mastectomy patients stayed over one night, which was equally terrifying because they stayed in non-COVID units, but they were afraid that at any given time, someone who is asymptomatic and walking through the hospital, one of their nurses, one of the, housekeeping, anyone from food services, might contaminate them or might infect them. And so they, those patients didn't even sleep that night. I round the next morning and say, how was your night? And they look terrified and they're ready to go. And Dr. Belisha, could you tell us about doing surgery, doing mastectomies under these conditions? And let's talk a little bit about wearing these masks for the people who are having some, I don't want to say difficulty, but I'm going to say that they are ill at ease. They're frustrated wearing the masks. Talk about it as a surgeon, because this is who we are, is what we do.
Right, exactly. So as you can also attest, we wear masks all the time. We breathe in our CO2 all the time. It's not a big deal. I have to tell you, wearing masks was easier when the weather was cooler. So I get it. You know, now that it's hot, it gets hot and uncomfortable, but I would rather be hot and uncomfortable than take the chance of getting coronavirus because, you know, I did help out in taking care of coronavirus patients. And as we had been talking about earlier, there was nothing sadder than seeing a patient dying, you know, hooked up to a ventilator, alone in a room with the staff not really, you know, trying to minimize going in. And I have to give a lot of credit to our hospital. There were teams that would call every patient's family every day to update them so that we would stay in touch, let them know what the treatment plan was. If they had questions, we would answer it. And we definitely used our iPads so that patient families could talk with the sick patients. You know, some of the sadder cases were patients who were dying. You know, the nurses were, you know, great enough to bring the iPad in so that the family members could see the patient one last time. So I think that's something that people really have to keep in mind. The vast majority of people who get coronavirus will not, you know, will have minimal symptoms, like as Ms. Barnhill you had. Thankfully, it was, even though you were immunocompromised because you were on chemo, thankfully you didn't get that sick. But about 20% of patients will need hospitalizations, as you needed, misspoke. And then unfortunately that 5% will just be so severely ill. And you don't want, nobody knows where you're gonna fall in that category. It's very random. I think the youngest patient I saw in the hospital on a ventilator was 27.
Wow.
And obviously patients with more comorbidities were definitely dying at a higher rate. So I would just say wear your masks. They're so important. It's you don't need the N95 mask, just a simple mask that will keep your germs to yourself. That's the way to think of it. Because I did have a patient come and see me in office hours who was a nurse, and she met the screening. So when people come to our clinical buildings, they need to get screened with their temperature. They're asked a set of questions. She passed all that screening, came upstairs to see me, and the next day she called and said that she had asymptomatically tested COVID positive. So I was like, wow, she made it through. So thank God she was wearing her mask. I was wearing my mask. I think the thing that we have seen in our hospital is that the PPE really works. There has been a low transmission rate amongst the healthcare providers because thankfully we didn't have issues with PPE. So if the masks can work in the hospital, they can definitely work outside.
Well, Doris was really blessed.
Yes, I was. I
mean,
agree.
because of your chemo situation, you know, God was with you, girlfriend.
I believe it.
Yeah, you know, and I think, you know, and even Maria, I mean, you know, we're all very blessed, but still having, you know, I've talked to so many breasties who are afraid to go to chemo. Just afraid to go because they don't even want to step foot in the hospital. You know, that's really kind of how we started the show, huh, Dr. Mo? I mean,
It's true. A lot of patients are afraid of radiation. They're afraid to come into their, you know,
Right.
and I'm seeing a lot of later stage disease. I have to be honest, because here in Pennsylvania, at least in Sellersville, outside of Philadelphia, the numbers are down for COVID-19. But I am starting to see patients now come in for screening, and really those who should probably have gotten diagnostic imaging. And for the last few months, they maybe have been a bit afraid to come into the hospital. And so I'm seeing more, as we call it, locally advanced disease that has spread to lymph nodes. And it's, you know, cancer is a tricky thing, and it cannot wait. If you have a lump, if you have an issue, if you have a skin lesion, if you are worried that you might have breast cancer, for those people who are watching, for your family members, please do go get imaged. It's not screening, it is diagnostic, and we will continue to do diagnostic imaging across the country, even despite COVID. So if you have an issue, please do get screened. But you're right, Ricky, is that we saw this as a way to really reach these patients and give them some knowledge and some encouragement, because the fear during this pandemic is nothing. It's like nothing we've ever experienced before, because we haven't.
Right.
You know?
Right.
And if you live in a state where the coronavirus levels are controlled, I think it's very important right now to get your screening while you have this window of opportunity, because there's no guarantee that a surge won't recur and a second peak won't recur. So now is the time.
I want to do a little round robin, and I want to start with Dr. Austin and ask if there are some tips that you have for people who might be watching, because, you know, we know 25 million Americans have asthma, and many of them live in our inner cities, and many of them are people of color. Are there things that people can do for lung health and to optimize their wellness to try to prevent them from catching the coronavirus?
Well, I always recommend that asthma patients have an asthma management plan so that they know what to do. I want to try to keep all of them out of the hospital nowadays, because who knows? They'll be in a hospital and the floor will have, 10 COVID patients. And a lot of management could be done out of the hospital. I guess it's different than chemo or a surgical patient. Although I do know that chemo can be done as an outpatient. But I tried to minimize the admissions, steroids if they needed over the phone, see them in the office, try to manage them without even coming to the office. But as far as a plan, yes, all my patients are usually on inhalers. When they have a flare up, I try to determine whether there's an infection or not. If there is, then I'll give them antibiotics if I think it's a bacterial infection. And then the main course would be steroids. So we would start with prednisone and taper it down over time. It depends on the type of asthma the patient has also, because we have some asthmatics that are really strongly allergic asthmatics, and there are some new medicines for that. But those are few and far between. And as a lung specialist, you should have a handle on whether or not your patient has that or not, because then they would be a candidate for some of the biologics that are available now. So basically, that's it. I can do X-rays from my office. We stopped doing breathing tests because of the effort that it would take for the patient to expel air. If they have pre-diagnosed COVID, I don't know whether patients come in and have it or not. The first few days, you may not show any signs of it. And then talking about the different tests, the nasal test is bad, but that's the test that you take to see if you have active disease. And the blood test really is an antibody test, and that's for whether you had it before or not. And nowadays, we don't know how long you carry antibodies, but anyone that has an blood test positive, then that means that they had active disease, and now the body is fighting it off and resisting it and producing antibodies to fight off the COVID disease. But anyone with a nasal swab positive, that person can communicate COVID to others, and that's why that nasal test is so important. I don't do the nasal test in our office. We send them to primary care physicians or to the hospital, which they don't like to do because they have to pay. We do have free testing centers that are opening up at various locations, and the lines are long to try to get your test done. But it's still good to know whether you're positive smear or not. So that's about it. So the asthmatics, eat healthy diet, avoid things that trigger you, cigarette smoke, obviously, pet animals if you're allergic, try to stay away from environmental factors that will trigger you, such as bleach or strong perfumes, colognes, and things like that. So that's about it.
Great. And let me go in reverse order. Ms. Barnhill, what do you want cancer patients to know or to be aware of, or what's the take-home message from this experience? What's the testimony from this test?
In conjunction with COVID, or just the cancer experience by itself?
Both, either, all.
Well, the cancer experience by itself, for me, I'll have to give Dr. Belisha a lot of credit. She comforted me a lot, in terms of preparing me for the surgery itself. For me, it was frightening because I lost a sister to breast cancer. And so I had because she was estranged from the rest of the family, by the time she came to us, it was already too late. And she wasn't one much for sharing her experience. So I still had no knowledge when I'm now undergoing this. I have no reference, no point of reference, nothing that I can compare this to.
Did
So,
you do genetic testing?
say again?
Did you do any genetic testing since your sister had it?
Yes, I did. I had the BRCA test done and it came back negative. So that was fine because I have, let me see, I have 5 sisters left. Well, there's 5 of us left in terms of
Okay.
girls.
So everybody
So-
should be tested, right?
Yes, and these are the types of things that conversations I've had with them, and they've come to me, and as I said to Dr. Belisha, they were very, how can I say, timid about asking me questions. They were like concerned about imposing on my privacy, and I had to explain to them that this is not private.
No.
This is something
Yeah,
that,
please.
yes, and it's something that I need for you to ask me any questions that you want to ask. Anything that crosses your mind, if I can answer it, I will. This is not personal. I have to share it with you because any one of you can get it. We can't go through what we went through with my other sister and not know anything. I think I should have been a little better informed had she been more, open with the rest of the family. So now they're coming to me and, asking me questions, and I'm like, asking anything that you need to ask me, and any question I can answer, I will.
What is with our Black families that we don't talk about this? Isn't it crazy? First of all, what breast cancer did you have?
Triple negative, Dr. Belisha?
Yes.
Yeah, I'm a triple negative. I got you. So yeah,
Mhm.
triple negative. And also the whole BRCA thing, I think we don't know enough about Black physiology. I really believe there's
Right.
we haven't identified yet. So especially with triple negative, because I don't have any gene mutations either, and I had triple negative. But what is it about our families? I'm sorry for the siren that we don't talk about it and we don't share.
Yeah.
Especially you had 7 sisters in your household.
Correct. That's right. And it's just not something you talk about. It's more open now with us because I, broke down that wall. No, talk to me, ask me. You've never experienced this. You don't know anything about this. We lost one sister. We don't know what happened with her. So you got no information from her. So ask me anything you want to know. And at the end of the day, they're constantly saying, thank you, because they had questions. And
Yeah.
they were afraid to ask. And I'm like, you need to know. You need to know. You need to know exactly what I'm going through. Here's pictures of what I look like and just everything. I just gave them everything. And they were very grateful. So sharing to me.
Yeah, I made everybody feel my tumor before I had it taken out and to feel what it felt like,
Wow. That's incredible, Ricky. I have to tell you, because I always say there's a couple things we don't talk about in Black families, and the first one's health and the second one's money. And those are the 2 things that we need to talk about the most.
every day, right?
Right, the most. Financial wellness and our health, our physical and mental and spiritual wellness. We don't like to talk about those things, but those are the tough conversations that we need to be having more and more. Now, with the COVID-19 experience, with the coronavirus, what advice do you have for people who are home and maybe they think they have it or they do have it and they're struggling with it? What can you say?
Get tested. That's the only thing I can tell you. Don't assume that it's the flu. Don't assume that you're just having a cold. You couldn't have convinced me in my wildest dreams that I had corona. I mean, it was just not something that I ever even thought about. It happened with me that on that particular day, I woke up, I felt like I had the flu. So, but it only lasted one day. The next day, those symptoms were gone.
You were blessed.
Okay. Yes. And then I started having the nausea and I started, couldn't keep anything on my stomach. But then that too left. So by the time they took the test and told me that I was positive for corona, the only symptom I had left was that I was exhausted. That was the extent of it. So there was no rhyme or reason to my particular COVID.
Yeah. Dr. Mo, I just got a message from our friends at Black Doctor that we need to end soon because they have a show at 6. And so we have a lot of questions in our chat, in the comments. So we'll try to address them offline, but we probably need to wrap up. I'm sorry.
Oh, I need to get Dr. Belisia's tips, and then Marie, Minister Pogue, I
Yeah.
need to get yours, and we'll get them in a list and put them in the comment section, because you have a number of things that you recommend for folks. I remember you said, I got a list of things that I think people should know and do with respect to advocacy. But really quickly, Dr. Belisia, what do you want people to know, and how can they reach you for more information?
20 seconds. Mhm.
So, real quick, again, in states where COVID is low, please go for your screening. Please, protocols are in place to keep you safe in our hospital systems. Please wear your masks. It's the way that we can prevent community spread of coronavirus and get ourselves out of the situation as quickly as possible.
Great. Well, thank
Great.
you all so much for joining us. We have to break. We would love to continue this conversation, but this has been The Doctor Is In, relatable, reliable, and real. And we will see you next Wednesday
See you
night
next
at
Wednesday.
6 p.m.
See you next Wednesday. Thank you so much. You guys are awesome. Be well. Be
Thank
safe.
you.
Thank you.
Take care.
Thank you.
Everybody be
Thank
Thank
safe.
you.
Thanks.
Bye.
Take care.
Thank you.
Bye-bye.
Thanks, Dr. Mo.
Love. Breasty love.
Oh,
Okay.
there's my breasty.